This lecture will go over trauma as well as environmental emergencies. Understand that as EMTs, we have to have a good fundamental knowledge of trauma management. And in some instances, we may be asked to give medication, especially when we're talking about environmental emergencies. Trauma is actually a basic life support skill, and emergency medical technicians are designed for trauma management. So this is something we're going to do an overview, have knowledge, talk about some of the new changes, how to treat injured patients. But we are born as an agency through the creation of treating patients who are victims of trauma. Traumatic injuries remain the leading cause of death in people younger than the age of 40. And there are different mechanisms of injury that can produce different types of injuries. So you always have to include a high index of suspicion. Always up triage your trauma patients. There are traumas that affect one portion of the body, and those are generally stable patients, but multiple systems that are affected by trauma can lead to an unstable patient with an inability to have that life balance known as homeostasis. These patients are at high risk of death and require specialized resources to care for them and in some instances resuscitate them. Those resources are not available at the scene or in your ambulance. Your goal is to transport these patients to those resources. That is the goal of emergency medicine at the scene. We have the golden hour, but EMS has the platinum 10 minutes. In that 10-minute span, you need to be able to assess the airway, do a breathing management, assess for shock, package the patient, whether it's immobilization or not, and transport them quickly and to the right facility. Get stories quickly or en route, and make sure if you need it, ALS is called early. As far as advanced life support is concerned, their goal is to aggressively manage the patient's airway. You need to focus on the ABCs in trauma management. Part of this includes controlling external bleeding. Optimally, we want to keep as much blood in the body as possible. So for your treatment of external trauma, you want to have direct pressure. Direct pressure will allow the body to begin the clotting process. It helps the body clot. If that's not working and you're dealing with an extremity, you want to elevate that extremity. Elevation allows gravity to assist as well as your direct pressure. If that's not working and you're dealing with an extremity injury with external bleeding that's uncontrollable, tourniquets are now correct treatment. Tourniquets are the last-ditch effort. Just understand that skeletal muscle can go 2 hours without oxygen. We'd rather deny skeletal muscle the oxygen and preserve blood loss and have a better overall patient outcome. When you're applying a tourniquet, it should be 2 to 4 inches above the wound. You can use the commercial products they have, a blood pressure cuff, but make sure you don't use a belt, rope, narrow material that can cause damage to the muscle. You just want to restrict blood flow. And make sure you don't loosen it once you have secured it. With internal bleeding, that's a little different. Patients may not exhibit outward signs of bleeding. And internal bleeding can have a mechanism of injury, like trauma, but it can also be non-traumatic, like a stroke, like bleeding ulcers, like an aneurysm, an ectopic pregnancy. All resemble trauma, but they weren't manifested from trauma. What's happening with this type of blood loss is hypoperfusion. There's been a breach in the cardiovascular system. You have to maintain good pressures in order to perfuse blood down to the capillaries so they can deliver oxygen and nutrients to the cells. If you lose that ability, that is known as hypoperfusion, and another name for hypoperfusion is shock. So the signs of hypoperfusion are what we call compensatory. The body is trying to compensate for a loss of blood, a rupture of the vasculature. It will do that by increasing heart rate, by going into the autonomic nervous system will be activated and will have sympathetic response. Increased heart rate, the bronchioles will dilate, and the arterioles will begin to constrict. We'll try and compensate for the blood loss and restore blood pressure. As we start to lose more blood, we'll try and maintain that blood pressure, but we'll shunt blood away from body systems. Now, the first body system that is shunted blood is the skin. So we're conserving what little blood we have. We've shunted it from the skin. How's the patient going to present? They're going to look cool, pale, and sweaty. The blood has been denied to the skin, so we've lost the color that blood provides, we've lost the warmth that blood provides, and we start to sweat profusely. So we see that as an initial response to compensation. How's the blood pressure going to be? It's going to be fine. 120 over 90. 130 over 100. Because we're compensating for blood loss by shunting blood away from the skin. That's great. Now, we're still losing blood. The next system to have blood shunted away from it is the digestive system, known as the hepatic portal system. It's your GI system that filters out the food products that you eat and takes the nutrients and brings it to the liver. Is about 30 to 40% of your circulating blood volume in your abdomen. That's a lot of blood that we can use in more important places like the heart, lung, and brain. So they're going to shunt blood away, and what's the patient going to start complaining of? Weakness, nausea, they may vomit. At that point, we know that we're at about 20% blood loss. Well, what's the vital sign going to be? Blood pressure is going to be fine because we're still compensating. But blood loss continues. We're still bleeding out internally. We're still bleeding out externally. We still have a rupture of the cardiovascular system that we can't repair. So we're going to have to shunt blood away from another system. And that system is the renal system. And the renal arteries shut down, prevent blood from entering into the kidneys. Since there's no blood entering the kidneys feel the body is dehydrated, and it will send a signal, and the patient will start complaining of thirst. At that point, they have about 30 to 35% blood loss. Think back on your trauma patients who have had these complaints: the nausea, the thirst, the sweaty skin. Looking at these patients will tell you how much blood they have actually lost by watching how the brain is shutting down the body systems. Now the problem with the renal system being shut down is that, first of all, it can't turn back on again, but also it can't filter out all that acid that's being built up in the bloodstream. All those cells that are being denied oxygen and are, instead of making ATP or adenosine triphosphate, the power pack of the cell, they need oxygen and sugar. They're being denied oxygen, so they're just burning sugar. And instead of that aerobic metabolism of sugar and oxygen, where CO2 is a waste product, they're only burning sugar, and lactic acid is a waste product. Now, while these organs can go about an hour with anaerobic metabolism of just burning sugar and kicking out lactic acid, the kidneys have to get rid of that acid, but the kidneys have shut down. So now the lactic acid is stuck in the body, and it's starting to destroy the other cells. And at that point, we start to lose our ability to maintain a blood pressure. And we begin to do what we call decompensation. And we can tell that happens because the blood pressure will begin to drop. So kidney function and loss of kidney function is the bridge from compensatory shock to decompensated shock. So when a patient tells you they're thirsty, you should be at the hospital already. That means that their kidneys are getting ready to shut down. With children, you don't see that. You don't see that skin, nausea, thirst type of spiral. Kids compensate a lot longer. They compensate differently than adults. Signs that they're hypoperfusing are very small. There's only a few signs, but one big sign that you have to evaluate is the capillary refill. Capillary refills should be less than 2 seconds. That is a sign of adequate perfusion. It varies with adults, but it is a standard for a pediatric shock. So make sure when you're treating a child, you always check the capillary refill. Blast injuries involve up to 4 different mechanisms. Okay, you have your primary blast, which is caused by the blast wave itself. But these people are thrown, and while they're being thrown, the projectiles coming off of the blast zone, the bomb or whatever exploded, are now shards like bullets, and that's your secondary damage. And then finally, while they're being blown, what are they being blown into? They go into a wall, they go through a pane of glass. That is your tertiary injury. So primary is the compression itself, secondary is the shrapnel, tertiary is what you got blown into. Primary blast injuries are going to affect your pulmonary system. You can have ruptured lungs. Neurologic dysfunction from blunt force trauma to the head is very common. And extremity injuries, especially if you have low-placed devices, like you saw at the Boston bombings in 2013, where the devices were low to the ground, cause lower extremity trauma. Head injuries are extremely serious because of the organ that it's there to protect is going to be damaged as well. So we can have different types of fractures of the skull. It can be open or closed. And we classify them as a fine one, as a linear. Depressed, we have actual bone that's going inward into the cranial cavity, or basilar, at the base of the skull. These traumatic brain injuries that become the product of the skull fractures are classified as direct injuries or secondary injuries that are brought on by the brain swelling. So you can have your primary injury where blood begins to collect at the injury site, but then the blood is encased in the skull. It creates pressure that pushes the brain down upon itself, causing this secondary injury. And because it's pushing down primarily, it pushes down on the areas of the brain that are the diagnostic centers, the medulla, the brainstem, where normal, everyday, mundane functions take place, like your heart rate, your respiratory rate, your blood pressure. All those things are regulated at the base of the brain. And when the top of the brain is bleeding and forcing pressure downwards, it's going to have an impact on that lower portion of the brain. And what are you going to see clinically? You're going to see problems with blood pressures. You're going to have that extremely high systolic and low diastolic. You're going to have bradycardias. You're going to have interruptions with respiratory patterns that are weird. Central neurogenic hyperventilation syndrome, Biot's breathing, ataxia. All this is brought on by that secondary brain injury. The most common cause of brain injury is a motor vehicle crash. You have the brain is encased in the skull, but it kind of floats around. So a sudden deceleration will cause it to lurch forward and then bang off the front of the skull and then lurch back. That's called coup contra coup. This brain bruising and any bleeding can lead to pressure. And that pressure can be enough to cause that secondary brain injury. In addition to the hemodynamic issues I talked about, the blood pressure and the breathing, everything, we also can have neurologic symptoms that show that there is pressure in the brain. We have decorticate or flexion, where the hands go towards the head, or posturing, decerebrate, extensor posturing, where the arms actually flaccid outwards. So here's your two. Up at the top is decerebrate, and the bottom is decorticate. I just remember the two because in decorticate, you're actually pointing your fist towards your vocal cords. Now this blood pressure, bradycardia issue I had is called Cushing's triad. Intracranial hemorrhage is where you have a buildup of blood inside the meninges, the dura mater, the pia mater. Whether it's outside, it can be epidural. If it's inside, containing the brain, it's subdural. Epidural hematoma causes secondary brain injury by causing that pressure. You can see how the dura mater is pushing inward on the brain, actually displacing it. A subdural hematoma, the displacement comes from the blood itself. Epidural hematomas work faster, subdural hematomas take longer to manifest. We can also have a hematoma where a vessel ruptures inside the brain. It can be traumatic or non-traumatic. But once it happens, the patients will start to deteriorate pretty quickly. Now the meninges, the layer around the brain and spinal cord that protects the delicate tissue has three layers. You have the outer layer called the dura mater. It's very tough, resilient, almost rubbery in nature. You have the innermost layer, it's called the pia mater, which is connective tissue that goes directly over the brain. And then you have a middle layer that's cushioning. It looks like a spider's web. It's called the arachnoid space. And in the arachnoid space is where you have your cerebrospinal fluid. So that's where the cushioning takes place. Right between the arachnoid space and the pia mater is an area called the subarachnoid space. And it has veins and arteries going through it, and it is prone for bleeding. And that is known as a subarachnoid bleed. Ways that you can tell in the hospital that you have a subarachnoid bleed is they do a spinal tap and they draw out cerebral spinal fluid. If there's blood in the cerebral spinal fluid, then they know that it is bleeding in the arachnoid membrane. A concussion is a head injury that results in temporary loss or alteration in the brain's functionality. It can be very minor, but the problem with concussions is that it makes the brain susceptible to more concussion, and it has long-term effects later on in life. Contusions, on the other hand, can be permanent in nature. So what are we going to do for these patients? Well, of course, the major thing to think about, because I described especially the secondary injuries with the pressure on the brain, it has major issues with airway management and respiratory. So we have to assure an open airway. You may have to ventilate these patients. Think about using an oropharyngeal airway. If you have a facial trauma, you don't want to use a nasopharyngeal airway. Give high concentration oxygen, control the bleeding if possible, and this is a patient who probably requires advanced life support because of the fact that they need aggressive airway management. Moving on to some specific injuries. Eye injuries. Remember, if you're dealing with a chemical eye injury, it's important that you cover both eyes. Eyes are accommodating, so if one eye looks one way, the other eye will look that way as well. If you cover one eye, anytime that the unaffected eye moves, the affected eye will move as well, causing possible further damage. Unless there's a chemical irritant in the eye, try to keep contact lenses in. And never exert pressure on an eye. Make sure that you clean it out. If you have a foreign object or a chemical burn, at least 5 minutes, go up to 20 minutes for irrigation of the eye to get whatever material or substance was in there. If you encounter an impaled object in the eye, stabilize it just like any other impaled object. Do not remove it. Cover the eye with a moist, sterile dressing. A 4x4 with sterile water or saline on it. And make sure that you bandage both eyes. For this, like I said before about the accommodation, if one eye moves one way, so does the other. Bandage both eyes. Blunt force trauma to the orbital socket can cause damage to the eye. Blood collecting in the iris and the cornea is known as hyphemia. And you can see a picture of it. You see that blood at the bottom. It's just collecting. It's drained down there. That causes pressure to the eye and potential blindness. Signs of a head injury can include constriction forced down on the optic nerve, which will lead to unequal pupils. So think about that. If you have a patient with unequal pupils, they could have a brain injury, but the amount of pressure you need to put down on, you could have a bleed inside the brain, so this is all part of your assessment. Always up triage. Facial fractures, we've got 14 bones in the front of the face. So direct blows can cause multiple fractures and multiple bones. So be careful. Bleeding into the mouth can cause airway obstructions. So can loose teeth. Facial fractures need follow-up care at the hospital. Unless you have airway considerations, they are not ALS emergencies. Dental injuries as well. Unless there's no airway involvement, there's no need for advanced life support. There is, however, the requirement for transport to the hospital. Injuries to the neck, fractures to the larynx can be disastrous and life-threatening. Not just will the patient have possible loss of voice, difficulty swallowing, but the swelling around the trachea will resemble an anaphylactic reaction and the patient could actually die. So this is something that would require advanced life support for aggressive airway management. When you're dealing with a trauma to the neck, assume that you have a C-spine fracture. These patients need to be immobilized. If you have a patient who has a jugular vein laceration, you're going to need to hold direct pressure. It can either be through a single-digit direct pressure or a sterile occlusive dressing. Signs and symptoms of laryngeal injuries include respiratory distress, hoarse mouth and speech, difficulty swallowing. There could be coughing up blood. There could be major swelling, bruising around the area. Once again, you're going to consider C-spine immobilization. If the trauma was enough to cause this, it could have been enough to fracture the vertebrae, so you have to be careful. Mobilize. This is a patient who would probably do best with advanced life support on board as well, and this patient needs to be transported. Spinal injuries. There are different types. There's fractures and there's distractions. Distraction is when it's pulled. Fracture is the actual bone is fractured, but most common spinal cord injuries are either the pulling or the misalignment, otherwise known as subluxation, or subluxation, I'm sorry. So these patients need extra precaution. In some instances, padding might actually be good on top of the spinal, on top of the cervical collar. These patients, especially a neck injury, could have complications with their brachial plexus and the nerves innervating from C3 to C5 that control your diaphragm. So these patients could actually stop breathing. So be very careful and be ready and prepared to ventilate. Moving down to the chest. Injuries to the chest can cause a lung to burst. When the lung bursts, it releases air into the pleural space. The potential space between the pleural sac that encases the lungs and the rib cage. The pleural sac protects the lungs from rubbing up against the rib cage. So air now is trapped and it goes into the pleural space and it creates pressure. It deflates the lung, but that excess air pushes the affected lung across to the affected side. And you can see this on the graphic. So on the left side, the patient's right lung has deflated. It's now moving across and is putting pressure on the heart and the unaffected lung. And while this air is building up, it's going to push further and further across to the patient's left side. Now there's different types of pneumothoraxes. The simple pneumothorax, the patient doesn't really present with any real clinical signs. They still need to be followed up at the hospital, but it's difficult to make that something. They just feel some mild chest pain. So treatments include doing a full assessment, giving them oxygen, and seeing other underlying issues. If it's traumatically induced, look for other things that might be at work here in addition to the simple pneumo. A tension pneumo is what I described, the shifting of all of your organs across to the unaffected side. Treatments for this include giving oxygen, possibly ventilating, and requesting advanced life support, since they can do a procedure known as a thoracotomy or a needle decompression and relieve the excess pressure and restore the balance inside the mediastinum so the heart works better. If you find a patient with an open, sucking chest wound, then you need to seal that hole, because sealing the hole will prevent air from entering. And remember, always seal 3 sides, so we have a nice flutter valve to let air out. Hemothorax, this is where blood is collecting. Heme is blood, thorax is chest, blood in the chest. A pneumothorax is blood and air in the chest. Either one requires the same treatment: oxygen, ALS request, and transport. There's a nice graphic of both of them. Cardiac tamponade is a buildup of fluid around the pericardial sac. The pericardial sac is there, like the viscera in the lungs, to protect the heart from rubbing up against the organ next to it, the lungs and the stomach, so it can beat appropriately and without any type of resistance or obstruction. When this pericardial sac fills up with blood, it will cause pressure on the heart and not allow it to pump effectively. And what you'll wind up with is Beck's triad. Beck's triad is muffled heart sounds, drop in blood pressure, and JVD. Jugular vein distension. There's a normal heart encased in the pericardial sac. This is what happens when fluid, air, blood gets trapped in there between, it squeezes down. What signs of this? Like I said, Beck's triad. The narrowing pulse pressure we discussed is a blood pressure, let's say 100 over, normal blood pressure should be 120 over 80 or 130 over 70. Narrowing pulse pressure means like 120 over 100. 100 over 80. So the difference between systolic and diastolic is not great. It's very, very small. 10 to 20 millimeters of mercury difference. So what's our treatment for these patients? High flow oxygen. You may need to ventilate this patient. Rapid transport. Fractured ribs can be benign and require little medical intervention. Some can be severe, some can cause pneumothoraxes and pericardial tamponades. So these patients should be evaluated at the hospital, give them supplemental oxygen, and transport. And if it's enough to fracture the rib, think about the mechanism of injury and increase your index of suspicion to where you would think maybe it might be an idea to immobilize these patients. More than 2 rib fractures constitutes a flail chest. And you'll have paradoxical movement as one side breathes in, the other side will breathe out. That is not good for supporting life and proper ventilation. So our treatment is to maintain a patent airway, oxygen, rapid transport. These patients need surgical intervention. A sudden compression of the chest is known as traumatic asphyxia. This was found a lot with motor vehicle crashes before airbags. It was a leading cause of death, chest trauma. People were under strain, thrown forward. They're traveling at 80 miles an hour. The car suddenly stops because it hit something. They are flying 80 miles an hour into the steering wheel. It disrupted the great vessels. We had traumatic asphyxia. One thing you can see about this is the cyanosis goes right from the neck up to the head. The absolute obstruction of the great vessels. If you find a patient in traumatic asphyxia, they have a pulse, you're transporting to the hospital, they need airway management. They need immediate transport. If ALS is on the scene, that's fine. Do not wait for advanced life support. Begin transport immediately. Have ALS meet you en route, or make it all the way to the nearest hospital if you have to ventilate the patient. Blunt force trauma to the chest, in addition to traumatic asphyxia, we can have blunt myocardial injury, where the heart actually is bruised. Problems with this can cause sudden cardiac arrest secondary to VFib. Where you've seen this a lot is in Little League Baseball, where the pitcher will throw, get a line drive back, hit them in the chest. It will disrupt the electrical conduction of the heart, and it could possibly put the patient into sudden cardiac arrest. So patients who are these blunt myocardial injuries, remember, make sure you know where your AED is, have it ready to go. This patient could go into ventricular fibrillation. They've defined that strike at a precise moment in time that will definitely bring on VFib as commotio cordis. And this is why Little League baseball fields are being asked to not only have AEDs there, but to have coaching staff knowledgeable in its use and CPR certified, because it will bring on VFib, but it has a great recovery with defibrillation, especially early defibrillation. Continuing in the chest, you've got your great vessels. You've got your aorta, you've got your vena cava, and any laceration of these great vessels is going to result in significant blood loss. So our emergency treatment needs to include oxygenation, ventilatory support, BVM. This patient may require CPR, and immediate transport to the hospital. Moving from the chest down to the abdominal portion. This is where we start to have our organs of digestion. But understand that these digestive organs contain products, not just your food that was introduced, processed, and waste products, but also all of the elements of digestion. The acids from the stomach, the alkalides from the liver, and the digestive enzymes from the pancreas. And we don't want them getting out of the digestive system, out of the small intestine, because they can do extreme damage to your organs. The solid organs that process and filter blood, like the liver and the spleen, are highly vascular. The liver is about 30% of your circulating blood volume in it at all times. The spleen is about 20% of your circulating blood volume. So that's 50% of your circulating blood volume is between these two organs. When one of them or both of them are lacerated, there can be significant blood loss quickly. So with closed abdominal injuries, these are true emergencies because there's very little pre-hospital we can do for these patients. Understand that people with these closed injuries can have referred pain. This is known as a Kerr sign. But as blood and fluid begin to build up, you're going to start seeing other signs. Bruising to the umbilicus, to the navel, and bruising to the sides, the flanks. But those are late signs of internal bleeding. Distension is going to come first. So it can take minutes to hours. So if your index of suspicion is high, the mechanism of injury shows that there could be internal bleeding, you need to make a decision early to transport. Now, open abdominal injuries, those are easier to detect, but once again, they're difficult to manage. These patients need to be evaluated at an emergency room because you'll have issues like protruding organs, protruding bowels. You need to encase them. You need to cover them back up. And the best way to do that is to mimic the normal structure of the abdomen. So let's think about that. You have a bowel protrusion. So what should be the first layer that's laid on top of it? A moist, sterile dressing. On top of that, you should put an occlusive dressing. That mimics the peritoneal sac. Then over that should be the fascia and the skin, which is a bulky dressing, a dry bulky dressing. So you have the moist bulky dressing, followed by the occlusive dressing to seal it, and then laid on top is your dry, sterile, bulky dressing. Different things can cause abdominal injuries. It depends on the velocity. When it comes to trauma, speed is everything. Whether it's a car or a bullet, velocity matters. It can exponentially incur more damage. A vehicle traveling 30 miles an hour with an unrestrained passenger won't cause as much damage as a vehicle traveling 60 miles an hour. A medium velocity weapon, like a 9mm, will not cause nearly the same amount of damage as a high velocity weapon, like a sniper rifle. Our treatment regimen should be the same. ABCs, manage life threats, control any external bleeding that you find, stabilize impaled objects that you find as well. Think about moist abdominal dressings, covered with your occlusive dressing, and then covered again by a dry, bulky dressing, and provide rapid transport. Injuries to the kidney can be caused by normally back injuries, flank injuries. Remember, these kidneys sit retroperitoneal. They're not part of the peritoneal sac, so they're not protected. They're kind of out there. But injuries to kidneys are usually caused by other injuries. There are other organs involved. Bladder injuries, patient feels like they've just had a rupture. They feel the tearing. It's painless though. And they'll begin to bleed either out of their penis or out of their vagina. So this is something that is a true emergency. Here's an example of fractured pelvis that would then rupture the bladder. So ruptured bladders are usually not isolated, they're multi-system. Injuries to external male genitalia, while having long-term effects, they're not life-threatening in the acute setting, but these patients obviously need to go to the hospital. Female genitalia can have life-threatening impact. We need to transport these patients. This is a sign of internal bleeding, any damage to the female genitalia. To the external genitalia, find out if there's a possibility they're pregnant. This could be a sexual assault. Remember, if you're treating a victim of a sexual assault, their body is the crime scene. So understanding that the life-threatening issue has been taken out of the picture, you might want to instead preserve the evidence and give the patient more psychological first aid than real aggressive management. Now, injuries that affect the musculoskeletal system, they can be caused by either direct or indirect blows, and athletically it can be twisting or high energy forces like being struck by a vehicle, being in a vehicle that's been involved in an accident, all different things that can cause orthopedic trauma. Now, what we used to call compound fractures, we call closed and open. Closed fracture, where you do not see the bone, and open fracture, where you do see the bone. And an open fracture is always caused by a displaced bone fragment. A dislocation of the joint can lead to serious permanent damage if not treated appropriately. An incomplete dislocation of a joint is called a subluxation. And a sprain is not a fracture of the bone, but instead a stretching, an overstretching, or in some instances a tearing of the joints and tendons. We can have strains, which is a muscle, which involves muscles and not bones, and an amputation, which separates a body part from the organism. What happens a lot with these fractures, especially closed fractures, is that they can be internal bleeding that can lead to pressure that's internal, leading to compartment syndrome. This is a potential complication. So patients with this type of syndrome, where the bleeding is internal and it's causing pressure on everything else and causing a reduction of blood flow to distal areas of the injury. Patients are going to complain of extreme pain distal to the injury site. They can get the area affected can lose its color. There's decreased sensation. So that's a true emergency. These patients need surgery to correct the compartment syndrome. How are we going to splint? Optimally, you want to splint in the position it was found. Always do a pulse motor sensory, not only before, but after application of a splint. If you are unable to feel the pulse, the patient has lack of motor or sensory function, you may attempt to realign once into the normal anatomic position. Gentle realignment to try and get blood flow back. If it's unsuccessful to restore pulse, motor, or sensory, you have to transport immediately. Submersion injuries. Drowning is defined as the process of respiratory impairment from submersion, immersion, and liquid. Now, what happens in a drowning incident is not that the fluid from wherever the pool or the lake is filling a victim's lungs, but instead the victim is drinking the lake or the pool. And when you drink, your epiglottis covers over your trachea so you don't choke on the water or aspirate on it. So while you're drinking this water at the lake, your epiglottis covers over your glottic opening to your trachea. That's known as a laryngospasm, and it causes you to suffocate. Any diving injuries have to be managed with spinal immobilization, along with the patient being unconscious that you find in the water, or if they complain of any neurologic issues, numbness, weakness, paralysis, or overstimulation. They feel like their legs are on fire. That's just as bad as having no sensation at all. Diving injuries, this causes a change in atmospheric pressure, which can have an effect on your cardiovascular and neurologic system. So divers are taught to slowly, not only slowly dive down, but also slowly emerge from the water. What happens with the change in pressure, there's a problem with gas exchange. Carbon dioxide and oxygen doesn't do the switch like it normally is able to do, and the patient feels like they're hypoxic. They start to panic. They get psychotic in some instances. Patients who rapidly ascend require aggressive resuscitation sometimes. They can develop air embolus. You may encounter somebody who just got home from vacation who is suddenly short of breath. It turns out that they went diving the same day as they flew out. Divers understand that they never dive the same day that they're flying. The change in atmospheric pressures are too much for the body to handle, and an air embolus, we call that the bends, can occur. This is known as decompression sickness. So in addition to shortness of breath, these patients also have abdominal and joint pain. And what's our treatment for these patients? We need to basically get them to a hyperbaric center. They need to have their nitrogen and oxygen levels changed and normalized. And this is an example of a hyperbaric chamber. So if you're dealing with patients who are victims of near drowning, drowning, or diving, and you don't suspect spinal cord injury, you can put them on the left lateral recumbent position. Remove any obstruction. Airway management is key. Airway, airway, airway. These patients will be hypothermic, so you want to provide warmth to them, keep them covered. For air embolus or decompression sickness, oxygen is key. Oxygen and transport promptly to the nearest facility where they can be scheduled for a decompression chamber visit. Let's talk about some other environmental issues you come across. Insect bites, like spider bites. There are only really two spiders that deliver life-threatening. You can be bitten by a spider and have an allergic reaction that will lead to inflammation of your skin known as cellulitis, but really the black widow and recluse spiders are the ones that have the neurologic issues. So a black widow spider, as you know, it's got the hourglass on the abdomen. It's a bright red-orange marking on a black body. They prefer to be in dry, dimly lit places, and they have neurologic issues of your somatic nervous system, muscle spasm, and it also can cause damage to nerve tissue. You get GI disturbances, rashes, you feel tight in the chest, severe cramping. It's a lot of musculo-neuro issues. For very severe bites, there's antivenom available. And once again, this is something that can be a transport from one facility to another. In hospital, for spider bites, is usually, for the muscle spasms, is benzodiazepines like Valium or Ativan. Now the brown recluse spider tend to live in dark areas. In rural areas, if you have a wood pile, that's where you might find them, also in closets. Now, while the venom doesn't attack the nervous system like a black widow spider does, it is cytotoxic, meaning it causes damage to cells. It'll cause local tissue damage. And a recluse spider bite is not painful in the beginning, but as the cells begin to die, necrose, it becomes very, very painful, and it can lead to loss of the entire layers of tissue, a limb, and even death. Now, bees, wasps, hornets, yellow jackets, and even ants are classified as Hymenoptera. And stings from these bugs can have, they're supposed to have just localized reactions, but people who have a sensitivity to them can develop anaphylaxis. So what do we need to do? Scrape the venom sac off the skin. Don't pinch at it, that releases more toxins. If anaphylaxis is occurring, patient's short of breath, they're closing up on the trachea, we need to think about an EpiPen. There are over 115 different species of snakes in the United States, but only 19 are venomous. But are you going to decide which one's venomous and which one isn't? No, let's make an assumption that they're all venomous. We have, of the venomous snakes, we have our pit vipers. Pit vipers have triangular shaped flat heads, and they have their fangs in the front of the jaw, and they actually run out and pierce to inject their toxins. Rattlesnakes can grow up to 6 feet, where copperheads are usually only about 3 feet. Copperheads, unlike pit vipers, inject their poison through a chewing method. So a rattlesnake will lunge at you and then retract. A copperhead will lunge at you and hang on and inject the poison by moving its jaw back and forth against your skin. Cottonmouths do the same thing. Now the problem with the venom that's injected by a cottonmouth is it's cytotoxic as well. So signs of envenomation is pain at the site, nausea, sweating, the generalized gastric, neurologic issues. Coral snakes have the bright red, yellow, and black bands. Emergency treatment for snake bites include calming the patient, cleaning the area, making sure you don't apply ice. That causes vasodilation. Only if they're hypotensive would you consider a constrictive band, like a blood pressure cuff or a venous constricting band we'll be using IVs. If it's occurring in the arm or leg, an extremity, then make sure that you hang the leg or the arm below the level of the heart when you're transporting. Make sure you monitor the patient's vital signs. They don't take anything by mouth, oxygen as needed, and transport to the closest facility. And depending upon your region and your department's policy, you'll decide whether you're going to go to a snake bite center from the closest emergency department. You'd be surprised how many emergency departments actually carry anti-venom. So here in New York City, of course, the snake bite center of choice is Jacobi Hospital. There are other hospitals that carry anti-venom as well. You might not have to take a trip to the Bronx. Scorpions are scary looking creatures, but their stingers are not lethal for the most part. The only stinger that has a lethal poison injection is the black scorpion. If you have a patient who has a scorpion sting, emergency care includes airway, breathing, circulation, oxygenation. You might need paramedics for pain management and immediate transport to the hospital. Some non-lethal bites you're going to deal with, like ticks. It's non-lethal in the acute setting, but in some instances, like deer ticks that transmit Lyme disease or Rocky Mountain spotted fever, these can have long-lasting effects. So transportation is still warranted. We're not that concerned about aggressive airway, breathing, and circulation management. Now, Rocky Mountain spotted fever can occur as early as a week up to 10 days after an initial bite, and there'll be some neurologic complications, but the problem is these patients can go into cardiorespiratory collapse pretty quickly. Lyme disease is more long-lasting. There's a rash that's like a bullet target about 3 days after the bite, and this can have some chronic effects with joint pain and weakness, paresthesia. So these patients, it's important that they get evaluated at the hospital, and they may not have acute signs and symptoms, but they still need to start an aggressive antibiotic regimen. Let's talk about electricity for a little bit. Electricity-related injuries. First of all, scene safety is paramount. Don't enter a scene unless you are sure it's safe and the power is cut off. Dangers with electrical burns involve the fact that the electricity is going to follow the path of least resistance. So it will use the patient's neurologic system, which is electrically charged, to travel going through the entry point to the exit. Using the neurologic system means that it's not a direct access. It'll usually exit out closest to the ground. So people who grab an electrical wire will have a minor looking burn on their hands, but they may have lost their entire heel of their foot when the electrical charge blew out. While it's traveling through there, it can also cause sudden cardiac arrest. It can basically defibrillate the heart. So these patients, once you've assured your safety and they've been, the electrical source has been shut off and they've been removed to your ambulance, we got to think about immediate treatment. CPR and AED is something that should be part of your, this may be more of a CAB assessment if you don't detect signs of life. If they're just taking a shock and they're conscious, think about the fact that their heart may have some electrical disruption, there may be some damage to the muscles, and you want to think possibly about immobilizing these patients because of the damage that could have been done to the musculoskeletal system through that tetany of the electrical impulse through. Lightning strikes are an extreme electrical emergency. Tissue damage can be severe, life-threatening, and lethal. There are three categories of lightning strikes. You have your mild, which the patient lost consciousness, can't remember the event, and they have some tingling in their extremities, to moderate, where they can actually go into respiratory and cardiac arrest. and severe where they have such extensive burns and cardiac arrest that they are unmanageable. Our treatments are going to be the same. Scene safety is key. Make sure you remove the patient to a sheltered area to do any treatment. Since lightning strikes, the old adage, lightning will never strike in the same place twice, never make that assumption. Take spinal precautions, especially when opening the airway. Never assume that there's no fracture to the neck because electrical impulse will cause that tetany that can disrupt muscles and cause fractures. If the patient's in cardiac arrest, use of an AD is indicated. Yes, I know they've just been electrocuted, but you're going to electrocute them again. Yes, you are. You're going to try and restore normal circulation through a controlled electrical impulse. So when we're managing our trauma patients, the key that's going through all of this, everything that I've discussed, is transport. Transport to the most appropriate facility. You got 10 minutes to finalize your assessment and any on-scene treatments before you should be rolling. When you're rolling, you got to make a determination on where you're going to go. Think about significant mechanism of injury, decreased level of consciousness, any threats to the airway, breathing, or circulatory centers. And remember, there are two ways that you can get patients to trauma centers. You have ground units and air units. Ground units, basic life support and advanced life support, but your air units are more critical care transport. Air medical services should really be used sparingly and meet certain criteria based on your state, region, and locality. But understand that if you're in a situation where you have an extended transport time to a trauma center, that would be when flight is necessary. 20 to 25 miles is an extended period. It cuts into the golden hour. If your patient needs ALS and there is no ALS service available, then you call for a helicopter. And if you think it's going to cut so much into the golden hour, what some things that can cut into the golden hour? How about extended extrication times? Maybe more than 20 minutes are going to cut to the golden hour. And what can we do as EMTs? We coordinate with fire and police, ask the fire chief, how long do you think this is going to take? Just give me a ballpark estimate. Is it 20 minutes? Is it going to be 10 minutes? If he goes, well, about 20 minutes, fine. Let's set up for a landing zone, let's call for a helicopter. Have that process of flight landing by the time the patient is extricated. It cuts down on your timing. Now remember, look at your state protocols. Review the state protocols on when it's necessary to transport a patient to a trauma center. Think about the Glasgow Coma Score. Think about how the patient presents. What's their underlying medical history? What's the index of suspicion? The mechanism of injury. Review your protocols to know when it's appropriate to transport someone to one of these specialty centers. Not only adult, but pediatric. Other instances to call for air medical, mass casualty instances, trying to avoid overflowing the nearest hospital, getting them to other facilities, specialized treatment. I'll be aware of the American College of Surgeons Trauma Center classifications. Part of the Emergency Medical Transportation Liability Act of 1980s involved creation of trauma centers. Trauma centers are the only hospitals that you can divert going to the closest hospital and go there instead. They're the only ones right now. Every other hospital, you need a physician order. So trauma centers have a unique criteria that allow you to direct yourself there. And trauma trumps everything. If the patient is found in a motor vehicle crash and you think he had a stroke prior to him getting into the car accident, and now he has significant head trauma and chest trauma, and now the car caught fire and he's burned, trauma center criteria. He meets that over everything else. New York State has the trauma center criteria. It's important when you're reviewing to know that protocol. Thank you.